All right.
There it is. It's all yours. I'm going to mute now, and you can share your screen or whatever you need to do.
Very good. All right. Welcome, everybody. Thank you. I am going to get started today. We're going to be talking a little bit about, I'm going to stick in the theme of environmental injuries. Last time we talked about drowning. So as we talk about drowning, last time we did that at the end of the summer. So now I'm going to be a little bit ahead of the schedule, and we're going to talk about hypothermia. So if you look really hard on the screen behind you, this is my home mountain, Mount Bachelor. And every year in and around the Deschutes woods that we live by, people go out in snowmobiles. I took this particular picture of Mount Bachelor from the top of Moon Mountain, which is a place that we go snowmobiling. It's also a place where people go snowshoeing, cross-country skiing, winter camping, etc. So it's a great outdoor area. Along with anything outdoor, we run the risk of exposure. And tonight we're going to talk about hypothermia and cold-related injuries. All right, hopefully that played for you. All right, we'll talk about hypothermia. In basic, it's defined as a temperature that's less than 35 degrees centigrade. As I move along, you'll see a lot of these are in centigrade and in parentheses Fahrenheit. The majority of the publications you're going to see, or the time when you're reading in your textbooks, you'll primarily read about degrees in centigrade, and those are the ones that you should commit to memory, because those are the ones when you have test questions, they'll most likely be in that form. Being in America, we tend to use the Fahrenheit system, but the numbers are a little bit cleaner with centigrade. And you might find as we go from slide to slide, I went through and paid particular attention to try and make sure that every slide agreed with the slide before it. But very often when you're looking at research for hypothermia and reading on treatment algorithms, etc., you'll find that there's some change from one text to another. And that doesn't mean that they're wrong, it's just sometimes not everything is universal. About 700 people die a year from hypothermia in the United States. Half of those are 65 years old, and the extremes of age are at risk. Just as we talked about last time about drowning, where the very young and the very old were at risk, when we talk about heat-related injuries, that's even more pronounced. The very young and the very old. The very young, because they have a much significantly different body ratio, their head's larger, their bodies are smaller. And with the old or infirm, they tend to have more secondary diseases, diabetes, poor circulation, and they're taking quite a few medications, which increase the risk of hypothermia. Now, how do we lose temperature? This same slide, when I give a slide on heat-related illness, meaning heat exhaustion, heat stroke, I use the same slide. There are 4 ways to lose heat. Conduction is the transfer of heat by contact down a temperature gradient. I'll show you what that means in just a minute. Convection is the transfer of heat by movement and heated material, such as wind. Radiation is the heat that you give off, the loss of heat from non-insulated areas. When you take off your hat in the wintertime, you'll see steam coming off the top of your head. And then last is evaporation or respiration, and that's the loss of heat through exhalation. So if you're walking up a mountain or stuck in the snow and you're trying to get out, you're going to burn up a significant amount of heat by respiration because you're going to breathe faster. These are relatively standard heat dissipation percentages. We lose about 55 to 65% of our heat from radiation. Conduction is about 2 to 3%. Convection, that which comes off. If you think of a convection oven, it's primarily just an oven that has a little wind tunnel in it, and that is about 15%. And evaporation is relatively high, 20 to 35%. How do we do this? Well, let's take a look at our gentleman here who's climbing and stuck on a rock. A couple of different ways. First off, he's conducting heat into the rock. As he sits there, the heat is going into the rock via conduction. Next, the wind blows, and as the wind passes him, it takes away some of his heat and thereby going through convection. Evaporation is going to happen as he is wet and then goes to dry. Now, hopefully in a cold environment, you're going to be covered completely and the majority of your evaporative loss is going to be minimized because you're going to be taken care of by warm, dry clothes. However, if you have wet clothes outside, you know that's a respiratory, or I mean, that's a recipe for disaster. And the last way is respiration. The harder you work, the more you radiate heat and respire, and you're going to lose. This is just another way to say the same thing. This is a soldier who's in the heat. He's conducting down into the ground. He's producing metabolic heat and work heat. He's also got convection coming off of him from the wind, radiation. He's evaporating by respiring and also evaporating through sweat. This is a useful slide to take a look at where we are on the scale. And the reason that I use this slide is hypothermia is a continuum. We all start somewhere normal. Most of us are approximately 37 degrees or 37.5. That's your standard typical 98.6. And then as we move down this scale, the colder we get, the more metabolic problems we go through. I'm not going to go through each of these on the slide because I will go through each of these syndromes in a few minutes. But you can see as you move down the scale, as your body core temperature goes below 35 degrees centigrade, that's the definition of hypothermia. So everything from 37.5 to 35 can be taken care of in the field by the majority of you, or just basic standard, either advanced life support or first aid. As the temperature gets below 35, these are the people that you're going to have to worry about and get them to the hospital. These are the people who are going to need eventually some type of extra warming and get them there as soon as possible. So let's talk about the three significant classes of hypothermia. Mild hypothermia is defined as about 33 to 35. That's around 91.4 to 95 degrees. Mild hypothermia, as stated in our last slide, we can take care of pretty much on our own. Usually, the body takes care of this through excitation, and you have physiologic adjustments to retain heat. What happens when you get cold is your body is designed to preserve the core and let the extremities go. You know this yourself when you're working outside, whether you're skiing or not, your core tends to be warm and your feet get cold and your hands get cold. Your body's figured out that it's cold, so your body starts to shunt blood away from the extremities in order to preserve the core. The body, meaning inside your spinal cord at your very base of your brain, that is simply run like a computer. When your body feels cold, it says, hey, it's cold, I might die. If I'm going to die, I can live without my arm, but I can't live without my chest. So it's going to shunt blood away from the extremities. Moderate hypothermia, 34 to 32 degrees, is an adynamic state. Metabolism slows down. We get a decrease in oxygen demand, and we get a decrease in CO2 production. Our body begins to say, oh, this isn't quite right. Now, remember last time when we talked about drowning, we talked about a diving reflex and how in mammals, as it gets cold, the metabolism slows down. Your body here is doing the same thing. And severe hypothermia, some people add a fourth class that I have not touched on, which is below 30 degrees, which some call profound hypothermia. It's found in some texts, so I left it out for the purpose of this lecture. In severe hypothermia, less than 32 degrees, or some would say less than 30 degrees, shivering ceases. So this is a test question. I, in fact, just reviewed it today for myself. It says, when does shivering stop? And the answer is at 30 degrees centigrade. So let's go back to our three syndromes. With mild, that's 33 to 35 degrees centigrade hypothermia, you get a mild increase in metabolic rate. Remember we said here, it's an excitation phase. You get a maximum shivering and thermogenesis. What your body is doing is, by shivering, it's trying to generate heat. It's trying to get the muscles to stimulate, contract, on and off by those centromeres gliding back and forth each other on the actin-myosin complex of your muscles. If you remember back to your physiology, as they slide back and forth from each other, it's actually creating heat, kind of like rubbing two sticks together. And that's your maximum shivering thermogenesis. You can begin to get a little bit of amnesia. Dysarthria is a fancy word for having a difficulty talking, or ataxia, that's a fancy word for stumbling or losing your balance. You begin to lose coordination. You can get tachycardic and tachypnic, meaning you're breathing, heart's going fast and you're breathing fast. Normally, you have a normal blood pressure. So in this very first phase, your body's starting to already begin shut down on the outside. What is interesting is the amnesia, dysarthria, and ataxia. Along with cold, you start to get confusing. And one of the things that I won't necessarily touch on, but it has happened in the past, is sometimes victims of hypothermia are found outside without any clothes on. That happens to be a thermoregulatory problem in the base of the brain, where the body perceives as it's really going down, that it's extremely hot, and because of this confusion, people actually wind up taking their clothes off. So very often, older people and people who are found out in freezing temperatures are found with their clothes off. Moderate hypothermia, 32 to 34 degrees, is the place where you first see stupor. There's really no shivering, although this is at the very bottom. 32 to 30 is when the shivering starts. Here you can start to get bradycardic changes and abnormal dysrhythmias. Your blood pressure goes down, your respiratory rate goes down. Your body is trying to conserve the brain because the body thinks it's going to die, so it's trying to conserve the brain by setting it into that diving reflex mode. The pupils become dilated at less than 30 degrees. In severe hypothermia, these are the people that you find passed out in the snow or passed out on a lake or something to that nature. These folks are usually comatose. What is quite interesting with these folks is they don't have a corneal or oculocephalic reflex. What are those two things? It's really odd. If you open up somebody's eyes, when somebody who is unconscious, they'll tend to stare straight ahead. We know that people who are perhaps feigning being passed out will kind of turn their eyelids up and look to the sky. But if you move a patient's head from right to left, they kind of fall like doll's eyes fall. So when you get severely cold, you lose that reflex. Also, if you were to take the tip of a Q-tip and touch it against an eye, that's an automatic blink, even if somebody has had a stroke. At severe temperatures, you lose that corneal reflex. The blood pressure continues to go down. You're more likely to see ventricular fibrillation. Your breathing can completely stop, and you may actually go into asystole. Your reflexes are not there at all, and your pupils can be fixed. And you can actually get a completely flat line EEG at 19 degrees centigrade. An EEG is different than an EKG. An EEG is an encephalogram of the brain, and an electroencephalogram, that's what EEG stands for, and the brain, it measures the brain waves. So at 19 degrees, the brain waves can actually stop. So let's see what happens we're talking about just basic physiology. For example, we talked about shivering. Above 32 degrees, you get vasoconstricting. Vasoconstriction happens because you're shutting down the extremities. You do have shivering, and you kind of increase your basal metabolic rate. Below 32, the shivering goes away, and at below 24 degrees, you actually have no basal metabolic rate. You're not burning calories anymore. You're more or less a popsicle. Hypothermic EKG changes happen with hypothermia, and they may induce life-threatening arrhythmias. I'll go over a few of these arrhythmias in a few minutes. Osborne or J waves, you're going to see those on maybe one of your tests, and I'll show you an example of those can happen. But you get some standard EKG changes. You can get Osborne or J waves. You can get inversion of the T waves all across the heart. And you can get QT prolongation or widening of the QRS. You don't get ST elevation. You don't get a STEMI looking picture with this. Your arrhythmias may be a slow heart rate or bradycardia, a very slow AFib, or you may have VFib or asystole. A typical progression is from sinus bradycardia all the way through the spectrum down to asystole. This is a good indication of a J wave. It was discovered by Mr. John Osborne in the early 1950s when he had some of his test subjects who had temperatures less than 33 degrees. He saw this in about 25 to 30% of the patient. And you can see what it is a positive negative deflection. So here's your P wave, you get a Q, R, S, and then you get this weird little up and down with this inverted T wave. This is what they look like on a 12-lead EKG. They're pretty distinctive. Sometimes they'll throw this question at you for a board question. Which of the following EKG changes can happen in hypothermia? And they might show you this, and you would say J waves. You can get T wave inversions as noted above, or you can get prolongation of QRS. But these are perfect examples of Osborne or J waves. This is another example. Here, this is another 12 lead where you can see circled the J waves. You can see they look different than ST elevation because they have this funky little ski jump. And that's how I kind of remember it for myself. If it kind of looks like a ski jump, you know, whoop, then ski jump is in the snow. Snow is cold. J waves happen when you get cold. Whatever mnemonic works for you. What's very important about the myocardium as it gets colder is it becomes extremely irritable, and ventricular fibrillation may be induced by simple interventions that stimulate the heart, including rough handling of patients. I have seen this question too, very often on board type exams, is why do you have to be careful? moving these patients is because if you raise somebody's arm or you're rough, all that cold and frozen water or blood that's in the patient's arm goes back to the heart. The heart is already irritable, and you can shock the heart by pouring cold water into it. Then you can send that patient into VFib if they had a perfusing rhythm. So, treatment, what do we do? And just like this picture shows, a little AVI here is you try and warm them up. First, stop further heat loss. So you're out on a rescue, or you're out with search and rescue, and you're searching for a missing hiker, and you come across them, and you find that he's fallen into the creek, and he's on the side of his either skis or snowmobile. First thing you want to do is stop further heat loss. You want to begin the warming process right there by passive external warming. That's, think about it, it's passive, meaning you're not doing anything active. External, on the outside, warming. Active external warming is a little bit different. I'll go over that in a few minutes. And then active internal warming, we'll go on that in a few minutes. So what you want to do most often is stop further heat loss. If they're in cold clothes, frozen clothes, if you're with a search and rescue team, you're going to hopefully have warm blankets, get them in warm blankets, or if they're in wet clothes, cut off their wet clothes and put them into dry blankets. That's the most important. This is a hypothermia wrap. You can do this in the field, or you can do it in the emergency department. Essentially, you're applying these little packets, the same little packets that you use to break, to put on an ankle for cold. We have them for applying heat, and we kind of wrap them up like a burrito and put them into their axilla, their groin, at the base of their neck, and try and warm people up. Active internal warming we'll go over in a few minutes. That's done in either the operating room or in the emergency room suite. So you want to, first off, we talked about not doing anything too exciting. So you want to maintain the horizontal position. We're used to putting people on a stretcher and raising their head, but the vertical position may compromise cerebral and systemic perfusion. Again, avoid rough movements and activities. You can start an IV if you need to, but try not to be rough when you're starting it. Be more gentle. Be very, very specific. You're going to take your time. You're going to do things extra, super slow, so you're not jostling that frozen extremity. Handle the victim gently during CPR as well, during intubation, bag valve mask, and vascular access. Everything you normally do in a hurry, you're going to try and maintain and slow down just a little bit. People can and will go into cardiac arrest. When we talked about drowning, I brought up a subject that we were saying nobody's dead until they're warm and dead. I'll talk a little bit about that in a few minutes, but essentially, if these patients have been out there for a while and they're into the third stage of severe hypothermia or profound hypothermia, they may be in asystole or a very fine non-perfusing rhythm. If they are in ventricular fibrillation, you can defibrillate. Now this says ×3. I'll show you in another slide, like right down here, some texts say only once. So some texts are going to tell you can defibrillate up to 3 times and then stop. Other texts will say defibrillate once and then just continue CPR. If you have the ability, you're back in the rig, and you have the ability to put in warm humidified oxygen to begin the warming process, that's great. If not, just use it. You would intubate people like you would any other time. If you're back in the rig and you can get warm fluids going, you're going to try and do that as well. If the temperature is less than 30 degrees, that's 86 Fahrenheit, you're going to limit your shocks to 3. You're not going to do your standard CPR and then circulate your medications and then defibrillate again, because until that myocardium warms up, it's not going to be reactive. So if you can get a rhythm back with 1 or 2 shocks, perhaps 3, great. If not, put the defibrillator away and just work on your ACLS CPR. If they're less than 30, you're going to withhold medications right now and continue the rewarming process. So let's assume that you found your victim. Let's say your ambulance is at the end of the road and you have gotten him back by snowmobile, continuing CPR, and it was a mile, and you're getting back now to the rig. We're going to start talking about this person as if they were in the rig. You're going to try and start the rewarming process. Rewarming methods, passive rewarming. We talked about the process where the body tries shivering. The metabolic rate goes up, your body starts to increase its thyroid production, and your body will try and do that on its own. But remember, we said below 30 degrees centigrade, the shivering will stop. Now you want to do things that will involve the decreasing of heat loss. So remove them from the cold environment, remove wet clothes, and provide a dry, warm blanket. Passive rewarming, as oxygen consumption goes up, as you get colder, you're going to try and get that up as much as you can. CO2 production can also go up. And you kind of shift the body into an anaerobic metabolism. So what you're trying to do is not trying to warm them super hot, super fast. So you want that rig to be uncomfortable. You want to keep them dry, but you're aiming for a rate of about 0.5 degree centigrade to 2 degrees centigrade per hour. You don't want to put them in a microwave and thaw them out. However, you're going to try and get them as warm as you can. If you're uncomfortable in the rig, meaning you're hot and you're sweating and you're opening up your clothes and you're super hot, then you probably have the right temperature in the rig to treat a hypothermia victim. This is the method of choice for mild hypothermia, and it's an adjunct to moderate hypothermia. Active external warming, you can use heat blankets. You know, some are fluid-filled, air blankets, radiant warmers. Those are the things that you have over your head in your rig. Sometimes they're bright red and warm. Now, this immersion in a hot bath, that's somewhat controversial. I suppose if you were in the emergency department and you could do that, it would be okay to do. However, it's not very practical. You can't do CPR when they're in a bathtub. You can't do your standard ACLS shocking when people are, wet. So this immersion in a hot bath is kind of a novel idea, but I'm sure somewhere, maybe on the top of some mountain in Nepal, where they do this all the time, they've got it figured out. But for our purposes, I think it's pretty impractical. Water bottles and heating pads, we already talked about those. Water bottles with warm water, and the heating pads, not so much the electrical pads, but the type that you can break, make sure they're covered and they're not in direct contact with the skin, because you don't want to burn the skin. Because these people will have, if they're truly hypothermic, will not have pain receptors working that'll tell you that it's too hot or too cold. And all these methods are less effective than internal rewarming because you have this vasoconstriction. There is some concern about after drop. What you will see is a clinical scenario that might be described as this. You found a hiker and you found him unconscious, but with a pulse. You put him in a warm blanket. You checked his temperature and it was 36 degrees. You then put him in the rig and then you drive him back to the hospital and now the temperature has dropped to 32 degrees and the patient is deteriorating despite the fact that you're warming them. What happened? Well, that's after drop. What can happen in after drop is you're warming the patient, he begins to vasodilate in his extremities, his circulation increases, and all that cold blood is dumped back into the core. So you have to be very careful that you're monitoring these people's temperature every 15 to 20 minutes. You're concerned with after drop, and really the best way to do this, and I know paramedics hate this, but the best way to get this is with a rectal temperature, because mouth temperatures or axillary temperatures are going to be no good. You're going to go for 1 centigrade to 2.5 centigrade per hour. You might have some circulatory problems by applying the devices to the trunk only, but that can happen. There's not very many good controlled studies comparing methods. A lot of this treatment is by not the seat of your pants, but it's essentially, this is what I found works. Because in order to do a truly scientific study, you would have to freeze half the population, and for a completely controlled group do nothing, and that's just not ethical. So there's not very good prescriptive controlled studies when we're doing these methods. Internal warming is done with warm IV fluids. If you have them, if you have a microwave, you can put a liter bag on high heat for about 2 minutes, and that will warm your IV bag. Most rigs I've seen can now carry warm IV fluids. We have warm IV fluids in the ER all the time. You're going to try and use warm humidified oxygen. These next 4 are strictly invasive, done in the emergency room. Peritoneal lavage, that means you put in a tube around the umbilicus or the belly button, and you pour hot water in that way. Gastric lavage will be the same thing. You'll put a nasogastric tube in, and you put in warm water into the stomach. You would put a catheter in or a rectal tube in and put warm water into the bladder or into the rectum. And there are some people who use chest tubes and put chest tubes in, and by putting those in, you get pleural and mediastinal lavage. Now, in the majority of patients, these 4 are relatively heroic. However, but if you've got somebody who's not perfusing, you have maybe on and off going between VFib and a bradycardic rhythm, and that patient has a good chance to live, you're going to want to try and warm them up and do the best you can. There was a study done, and probably it's been at least 20 years since the study was published, but some of the greatest survivors happened right here in my home state of Oregon here. And that was, it was a spring day when a large group of students went hiking on Mount Hood. And then as they got to the top or near the top, there was a freak storm and they were all caught. Well, they dug a cave and they all kind of got into the cave. And I think we were talking about 20 to 25 students. It was almost several hours before they were actually able to get up there and retrieve them all. There were quite a few deaths, but the ones that actually survived the best with the least problems were the ones that were transported to those hospitals that had the ability for a cardiac surgeon to bring them to the operating room and actually put them on a heart-lung bypass machine. And that warmed them as quick as you could. So these are all novel ways that might be done in the emergency department, but probably this extracorporeal circulatory warming that's putting them on a cardiac bypass machine would probably be the most effective. Diathermy, there are machines. Sometimes you go to the physical therapist and you'll see a diathermy machine. It's a very low frequency microwave that essentially points towards your body, excites the water molecules in your skin, and warms you up that way. Novel approach. I've never seen one in any emergency department that I work in. Fluids, plain old saline. You're not going to use lactated ringers. Shorter tubes if possible, because the more the heat goes through the tube, the more heat that you can lose. You can microwave, as I said, saline, 1 liter of normal saline to 39 centigrade. That's about 2 minutes at high power in most standard microwaves. Don't use microwaves for blood. Blood comes from the lab cold, so if you have to give blood, you're going to give it cold, because if you microwave blood, you get hemolysis and breakdown. Warm humidified oxygen. You're going to prevent heat loss, and you're going to get negligible heat gain with warm humidified oxygen. It's very important in the management of hypothermic patients. Remember, our very first slide or third slide, we talked about up to 30% is through respiration. So if you're respiring warmer air than you're breathing in, you're going to maintain your temperature. Now, beryllium is recommended for VFib and hypothermia patients. It's older medication. However, it kind of was removed from the 2000 ACLS algorithms because it's not, no one carries it anymore, and it has a high amount of side effects. It's still recommended in some textbooks. If you talk about the best medication for ventricular fibrillation and hypothermia, beryllium seems to have the best chance of returning to a spontaneous circulation. It was based on dog studies, and again, dog studies are different than human studies. This is just a copy of our Central Oregon hypothermia protocol. What I'm going to I'll zoom in right here, and it's just basically what we talked about. Remove the wet clothing, prevent heat loss, maintain horizontal position, avoid rough movement, monitor the core temperature, that means rectal thermometer, and monitor cardiac rhythm. So you can have you guys are all the new students. Guys are the ones who probably have to get the core temperature. That's the way it goes. Your ABCs, and if, again, your ABCs aren't going, you start your defibrillation process. You'll see here in our protocol, it says 1 shock. And then it talks about mild, moderate, and severe, as we did. All right, so we're going to leave hypothermia treatment, and we've gotten that patient back into the emergency room, and we've got the paramedic student maintaining rectal temperatures. We've got the nursing student putting warm water into the bladder. We've got the thoracic surgeon hooking the patient up to a bypass machine, and the emergency physician is going for a cup of coffee. Now, let's talk about extremity weather injuries. There are, first off, 3 different types of injuries. There's non-freezing, freezing, or associated injuries, snow blindness and dehydration. We're not going to spend much time on these other than the fact that snow blindness can happen. We just went through the eclipse. The same type of blindness that people get from staring at the sun can happen. It's a burning of the retina. It's very difficult. That's why the majority of people need to wear sunglasses when they're outside. And dehydration, again, we talked about that respiring loss and all that intense loss of fluids by increasing our respiration so we can get dehydrated. The 2 other categories are the ones that we're going to see most often. Non-freezing injuries are plain hypothermia, which we just talked about. Chilblains and trench foot, we'll talk about briefly. And then the freezing injuries, frostbite and frost nip. First degree, now frostbite or frost injuries are pretty much the same as burns. first, second, third, and fourth degree. First degree burns in heat-related injuries is a sunburn. Frost nip is a cold burn caused by the cold. There's a partial freezing of the skin. It's the very most superficial form of frostbite. There's really no permanent cold weather injury there. You get redness, mild swelling. The skin can pale. As you can see, this patient, his cheeks are paled right there. And there's a little bit of swelling or edema. Treatment is simply to warm. Now, can first degree go on to second degree? Yes. Remember how we talked about that thermometer? All of these are a continuum. So if you don't remove a patient, or the patient doesn't remove themselves from the environment, first degree can go on to second degree, third degree. Second degree frostbite, these are the clear blisters. There's some numbness and burning pain. The entire epidermis is affected. You get skin redness in fair individuals. You get grayish discoloration in darker skinned individuals. So if you have a black patient, their skin actually becomes gray or whitish gray. It's a clear blister, and it usually forms like 24 to 36 hours after the exposure. And it's persistent cold sensitivity in that area. Sometimes if you've gotten frostbite, you're going to have susceptibility to get it again at a much lower temperature, but also you might have that pain associated with frostbite all the time when you go out into the cold. Frostbite is a true freezing injury of the tissue. So the tissue is actually freezing itself. The onset is signaled by a sudden blanching of the skin, of the nose, the ears, cheeks, followed by tingling. It's going to start in those places where you're exposed. Frostbite has declared itself when these areas are painless. So unlike the very first where you get erythema and a little bit of tingling, frostbite tends to be less painless. As long as you can feel your toes and they're painful, it's probably first degree or some other form of hypothermia in the extremity. When it becomes painless, that seems to be something to worry about more. Third degree frostbite. One more in between, if I can talk about frostbite. We talked about secondary frostbite with clear blisters. There is, as second degree can progress to blood-filled blisters, and these can go over joints, etc. So those are also possible in frostbite. Third degree frostbite, you get this blue-gray discoloration, and here's where you get true bleeding blisters. They're hemorrhagic, they're blood-filled, and there is, just like a third degree burn, where you can't feel a burn that's third degree, you get loss of sensation with pale yellow, waxy looking skin, and you get poor capillary refill. There is going to be a significant amount of tissue loss, and these hemorrhagic bullae, these blood-filled blisters, will form in third degree injuries at about 12 to 35 hours. Generally what happens in the emergency department, I'll see a patient, generally it's a homeless patient. Sometimes we'll get a stretch here in Central Oregon where we have 5 or 10 days in a row where our temperature is below freezing, or at night the wind chill factor goes down to 10 to 20 below, and the homeless people will huddle, and very often, invariably, at least once or twice a winter, I'll get a homeless person who comes in. They tend to have, bad shoes, or they don't keep their feet dry, and then they come in and their feet look like this picture here, and they'll have hemorrhagic bullae, which means they've already kind of frozen and thawed already. So I usually wind up admitting those types of people. Fourth degree is the worst you can get. Blue, deep aching pain as it's down to the bone. You might get some red discoloring 1 to 5 days after the injury. And it's characterized by gangrene, necrosis, and autoamputation. Very often, these toes will just come off on their own. Sometimes I'll admit these people and I'll have an orthopedic surgeon take a look at them, and it's just a matter of time for their toes kind of pop off or snap off eventually.
Okay, I lied about the traffic. These dudes aren't totally mental. Just getting big air is dangerous enough. That's why they picked a mountain road nobody ever drives on, except during ski season.
All right. Therapeutic and non-therapeutic hypothermia. This is a case that we had here not too long ago in Bend. So one of my ambulance crews had this. Last time I talked to you about the ice family. Those are the people who fell in the water. Out on the ice, this is a different type. It's a 40-year-old male with a history of depression and IV drug abuse, heroin abuse, and methamphetamine abuse, and post-traumatic stress disorder. He attempted suicide with an intentional overdose of heroin while in the homeless shelter. So this, going back for history, he found out that one of his friends, he had asked one of his friends for some heroin. The friend didn't know he had intended to overdose, but this, because of the post-traumatic stress disorder and depression, he had decided to intentionally overdose himself. His friends discovered him and spent quite a few hours trying to revive him and resuscitate him for his heroin by injecting him with methamphetamine. Maybe a good idea as far as sympathomimetic effects of methamphetamine, but it certainly did not help him. The time was November here in Central Oregon, so it's relatively cold. After failing to revive their friend, they decided to transport him directly to the emergency room. They did not call the paramedics, and the patient came in by private vehicle. The patient was breathing very, very minimally, and what they decided to do was stick his head out the window. It's kind of the driving to the hospital with his head out the window, trying to simulate positive pressure in a unique way. By hanging his head out the window, they drove really fast to the hospital. They figured he would get oxygen that way. The patient was left at the ER entrance. They just kind of dumped him. And once they, one friend, it was actually a woman, decided, they were pulling away. She said, "Stop, I got to tell them what happened," because they're just going to see a dead guy in their entranceway. So on arrival, his blood pressure actually, maybe the methamphetamine helped a little bit, was 93/68. His oxygen saturation was 55%. So the open airway method of airway management was questioned. Probably not a good way to get oxygen into somebody. His temperature was only 31 degrees centigrade, and he had a GCS of 8.215, so he was completely out of it. His pulse was 80, and his respirations were only 6. So these are various ways that you can do airway management with your head out the window. These are the dog studies. So on arrival, he was given Narcan because it was first IM because there was no IV available. And then they started an IO. It was placed in his upper tibial area. IV rapid sequence induction and intubation was done, and there was vomitus noted on the cords, and the patient was intubated without difficulty. A central line was begun by a member of the trauma team in his right groin. His blood pH of 7, which is not unlike any hypothermia victim that I've ever seen. They tend to have a low pH and a falsely elevated PCO2 and falsely elevated PO2. So both of those, the normals are in parentheses, were elevated. His saturation was only reading about 72%. His drug screen, urine drug screen, was positive for methamphetamine and opiate. He was admitted to the ICU where he spent 4 days on a ventilator. He wound up getting some pulmonary edema, which was from the heroin overdose. He also had an aspiration pneumonia. He probably remembered we found vomitus in his mouth, so he vomited somewhat, and then that caused a pneumonia. He had a rhabdomyolysis, meaning breakdown of tissue products, and slow rewarming using an Arctic Sun warmer. He did get a psychiatric consultation because he was an intentional overdose, and he recovered apparently well. All right. So that's all I have. I'll open it up to any questions. I'll stop sharing my screen here. And if you have any questions. Okay. Why do we start breathing faster? This is from Chris. Why do we start breathing faster? Isn't there less of an oxygen demand? Well, early on in the hypothermic process, you remember you're in a catabolic state and you're increasing your oxygen demand. So your muscles are trying to keep up, your muscles are beginning to twitch, and you're most of the time doing some kind of excessive exertion. And because you're exerting, you're going to increase your oxygen demand and breathe faster. Different from a bunny ear bundle block wave? Yes, it is. The question, if you go back to the J wave, is it different than the bunny rabbit ears of what would be like a right bundle branch block? Remember that in a bundle branch block, you come down from the top of the atria, you hit the ventricle, and then the ventricle fires at two different rates. That's why you get bunny ears in a ventricular wave that is characteristic of a bundle branch block. The J wave is different. It looks a little bit like a bunny ear, but it's different. It's closer to the T wave or the QRS complex, and it has that little scoop on it that almost looks like a ski. I guess Jane was laughing at my videos. Any other questions?
Of course, I was laughing myself to silly over here. Those were good. I like the videos.
All right, that's my every 10 rule. I got to keep you awake every 10 slides so you don't fall asleep.
Were you keeping us awake, or were you keeping yourself awake with those?
Oh, both. Absolutely.
All right. Anybody else got anything else for Dr. Eschelbach?
Yeah.
Tad likes the 10 rule.
Okay. Well, assuming the question is a bag valve mask, is there a reason why it says mouth to mouth? Well, keep in mind some of these slides are from my lectures that I give to search and rescue. Sometimes search and rescue is just you happen upon somebody and you may not have your equipment with you. So yes, of course, your first choice would be a bag valve mask. If you've got nothing else, mouth to mouth is kind of out. We don't do it as much, but it's certainly a possibility. Yes, exactly. Most of the time, you know, when I was an intern, I did mouth to mouth on somebody and they promptly vomited in my mouth. And that's probably the last time I did mouth to mouth resuscitation. So all you have to do is do that once and you probably never want to do it again. Sorry.
Been there, done that, got the t-shirt.
Yes.
All right. Looks like everybody's pretty happy. It was a great lecture. If you would click the record button again, that will stop the recording, sir.